going to talk about the management of gastrointestinal symptoms and dysautonomia, but with a focus on the type of evaluation that I have my patients undergoing. And I'm going to put in there some of the physiology and the reasons why I think that this type of evaluation is necessary in many patients. I don't have any disclosures today. This is a general outline for the flow of my talk. I'm going to do a basic introduction, and then I'm going to give you some views from the gastroenterology clinic, and then go through kind of systematically a typical evaluation that I undertake. So this is just to make sure that we're all on the same page. This is a schematic of the human gastrointestinal tract, and there's a couple points that I want to make. Is that this is a very long tube with diverse functions that take place at specific regions within the gastrointestinal tract. And so your stomach is primarily focused on food bolus processing. And then when you get into the small intestine, these smaller particulates are actually released in appropriate volumes so that your small intestine can focus on macromolecular breakdown, absorption of nutrients along with water. And then when we get into the colon, the main function of the colon is actually for waste storage, more water absorption, and then stool formation, and then eventually evacuation. The other thing, because this will be important a little bit later on, that I want to draw your attention to is the number of microbes that are present in each of these sections. So within the stomach, we actually have very few microbes that are residing there consistently. We do have microbes that we intake in our diet that pass through the stomach but don't reside there long term. And then we have slightly more, so 10 to the 5 in the small intestine. And then as we get towards the end of the small intestine into the ileum, so right before we empty into the colon, we actually increase in numbers. But none of these are as high numbers as in the colon. And so when we talk about sort of microbial dysbiosis in the future, we'll sort of come back and review this again. The other thing I want to go through is what the layers of the gastrointestinal tract look like. And so, I don't know why it's... So just to orientate you, this here is the inside of the gastrointestinal tract. So these finger-like projections are inside the lumen of the gastrointestinal tract. And then you have these multiple layers of muscles with interspersed nerve fibers and larger nerve plexi. Within here, you also have blood vessels. And so this will be important when we talk about some of the other things, but just so we're all on the same page to start. So how do I think about dysautonomia within the gastroenterology clinic? So I'm going to start with a couple definitions so you know what I'm talking about. So review of systems, I'm sure you guys have all filled these out extensively for every physician you've ever seen, but just so you know, it's a description of symptoms related to a particular body system. So it can be related to the cardiac system, the pulmonary system, or the gastrointestinal system. And then comorbid conditions, these are other diagnoses or conditions that one has. And so when I see a patient in clinic, and I just sort of want to remind you that not everyone I see initially knows that they have a disorder of the autonomic nervous system. Sometimes this is me picking it up and sending them for confirmatory diagnoses. But many of you that come to see me actually know you already have this diagnosis. But what I do is I start with a detailed history and physical examination, so well beyond just gastrointestinal symptoms. Usually I want to start when you first got sick. The vast majority of my patients are female, and they've already been seen by usually a huge number of physicians in a bunch of different specialties. They typically report a constellation of symptoms, and I'm sure none of these are unusual for you. I mean, we can start at the top with brain fog, headache, dry mouth, dry eyes, palpitations, shortness of breath, and numerous gastrointestinal symptoms that usually range from difficulty swallowing to even just like what we call globus sensation. That's that persistent feeling that something's stuck in your throat and you kind of keep swallowing to try and clear it, but you don't have like a true impaction within the esophagus. All the way to abdominal pain, nausea, vomiting, constipation, diarrhea, or some alteration in between. And so historically, within the realm of gastroenterology, and even when I came through training, the inclination has been to diagnose people who come in with this constellation of symptoms with a functional disorder, such as irritable bowel syndrome. And this is completely incorrect. So that terminology describes a cluster of symptoms, but does not give you a diagnosis and does not impart any understanding to what the underlying pathophysiology of your symptoms are. So typically, functional gastrointestinal disorders are symptoms that do not have an identifiable structure or biochemical basis. And everybody pretty much agrees on that. However, many of these disorders we've actually been able to resolve when we understand what the cause is. The reason I'm showing this slide is I actually find it's helpful when I talk to other physicians who think that the patients that I'm seeing have a psychiatric illness. And so the point that I make with this, if we look at the innervation of the autonomic nervous system, it innervates just about everything. And so when something with the autonomic nervous system goes awry, it's not surprising that you have all these symptoms. And so if you look at the sympathetic branches and then the parasympathetic branches, these two systems have different functions. And I know many of you are probably familiar with this, but the sympathetic nervous system is your fight or flight. So when this system is overactive, it shuts down digestion. And so what we see in individuals with an overactive component of the sympathetic nervous system, we see a lot of delay in different regions of the gastrointestinal tract, a lot of difficulty with eating. And then with the parasympathetic nervous system, you can see the opposite. So you can see a lot of really persistent diarrhea that we have a difficult time managing. But again, the autonomic nervous system is innervating everything. It's not unusual for you to have all these symptoms. It's not unusual if your symptoms are exacerbated by stress. That again does not mean that you have a psychiatric illness, no matter what your physicians tell you. What I don't understand when I am seeing you guys in clinic is, does the gastrointestinal dysfunction come first, or does the dysautonomia come first? It's essentially a chicken or egg problem. And so the thing that I struggle with is, in order to make your gastrointestinal symptoms better, do I have to treat your dysautonomia? And if your dysautonomia gets better, can I expect your gastrointestinal symptoms to get better? And I think that is the case. And so I think there are specific things that I can do as a gastroenterologist, but then there are other things where we actually really have to address the underlying dysautonomia. One of the other problems is I feel like it's really important to understand what comorbid conditions you actually have. And I know there's some debate about this, but I think it's important to know whether you have an underlying connective tissue disorder, whether it be EDS or some other, whether you have presence of mast cell activation syndrome or a metabolic disorder or an autoimmune disorder, because all of this is going to change how I approach the symptoms that we have to address for you. So I typically recommend a thorough evaluation so that I can put together an entire clinical picture and sort of make better recommendations. And so what I'm going to go through here is the evaluation that I have most of my patients undertake. And it's not in any specific order. I just tried to organize it so maybe if we talked about one topic, it would relate to the topic before. So we're going to start with motility testing. And just so we're all on the same page, a couple definitions. So motility describes movement. And so essentially when we're talking about it in reference to the gastrointestinal tract, we're talking about coordinated movements. So we're talking about appropriate contractions in one segment, relaxation in another segment, and then that sequential change throughout time. So as you go through the entire gastrointestinal tract. Transit time is in reference to the time it takes to move through a segment. So the time it takes your stomach to empty, the time it takes food and things like that to move through your small intestine, the time it takes things to move through your colon. And then manometry, it's a measurement of pressure. So this helps us understand the muscular strength and the coordination of the different regions that we look at with manometry-based studies. And then lumen is just inside of the gastrointestinal tract. So that's when you get endoscopy done, that is done through the lumen of the gastrointestinal tract. So we're seeing that luminal surface. And then intraluminal pressure measurement means pressure measurements from inside the lumen of the gastrointestinal tract. And this is where your manometric-based studies are all performed. So there are essentially, in my mind, 3 types of motility testing that can be ordered. So your basic, very basic transit time studies include nuclear medicine, gastric emptying studies. All this tells you is how long it takes solid food to empty from the stomach. It gives me no indication about the muscular coordination, contraction strength, or anything in that regard. There are other scintigraphic-based studies that can look at transit throughout the small intestine and the colon as well. But again, these are just giving me time course measurements, nothing else. Sitzmarker's study is the same. This gives me a transit time through your colon, but nothing else. When you get into the manometric-based studies, there are a number of them. Performed at most institutions include esophageal, so they're looking at esophageal motility, and anal rectal, where we're looking at the coordination of your pelvic floor. There are 2 other specialized types of manometry. So there's antroduodenal jejunal. So this is a manometry test that can measure the muscle strength and coordination starting at the end of your stomach, so the antrum, through your duodenum, which is the first part of your small intestine, and into your jejunum. And so it's looking at this sort of coordinated movement through that region of your gastrointestinal tract. And there's a lot of disorders there, especially in individuals who have difficulty with eating. And then colonic manometry specifically looks at the motility within the colon. I'm going to talk in detail about the SmartPill wireless motility capsule because I actually think this is a really fantastic device because it can actually give us measurements on intraluminal pressure. It can give us transit time measurements, and I'm going to show you some data a little bit later on that I think that it may actually be a replacement for the gold standard of antroduodenal jejunal manometry. So I'm just going to give you the first example, which is esophageal manometry. And so just to sort of take you through this, you can see the diagram of the, does this show up? Well, you can see the diagram of the esophagus on my left, and then you see the pressure measurements. And so the catheter is placed through the nose. Many of you may have already had this, through the esophagus, and it terminates in the stomach. And then what it does is it looks at the pressure within the esophagus and the coordination of muscular contractions with swallows. And so what you want to see is the pattern that you see there is that you do not want to see all the segments of the esophagus pressurize at once. You want a coordination of contractions so that you actually are moving the bolus of food or fluid sequentially down the esophagus, okay? In individuals with dysautonomia, I was actually kind of surprised by this, but now in retrospect, I'm not. There are high rates of minor disorders of esophageal dysfunction. And if I talk to our foregut surgeons at the university, a lot of them want to take these patients to the OR, and they think they can surgically correct this. This gives me pause because it's possible that if we could actually improve the dysautonomia, we could save you a surgery. Plus, many of you decompensate whenever you have a big procedure done. So I try to keep you away from the surgeons if I can. And so one of the questions, we're working on a study on this, is to look at individuals who have these minor disorders of esophageal dysfunction. If we can actually improve your dysautonomia, will these actually go away? And so then we'll know the answer to that question. And then, what about in individuals who have an underlying connective tissue disorder with tissue laxity? I don't like to see you go to the operating room for anything. We know that you have higher rates of surgical failure for these kind of common procedures. So I definitely would not recommend that unless there was a really good indication. The same thing for anal rectal manometry. We see really high rates of pelvic floor dysfunction. We know the autonomic nervous system controls the pelvic floor. So can we expect that these disorders would actually get better if the dysautonomia gets better or improves? And then again, the same question arises, what about individuals who have a connective tissue disorder? I don't like to see them go to the operating room for these procedures either because their outcomes tend to be poor. So now let's switch gears a little bit and talk about the gold standard of antroduodenal jejunal manometry. This is only available at very specialized centers. And the reason that it is the gold standard is that people think that it can differentiate between a neuropathic, so a disorder of the neurologic system, or a myopathic disorder, a disorder of the muscles. I'm going to show you some data that calls that into question. What you can see here on my right is the catheter being thread. It's through, again, the stomach. It goes through the duodenum and into the jejunum. And it has these solid-state sensors on there that can simultaneously measure contractions. And what you want to be able to see, just like in the esophageal manometry, is that you don't have all the contractions taking place at once, that you have this sequential, as you move through these different sensors, you have this sequential contraction that's successfully moving food bolus through the gastrointestinal tract. And then again, when we look at the entire gastrointestinal tract and all its layers, there are lots of layers of muscles, and there's lots of nerves there. So there's lots of opportunity for things to go wrong. This article that was published in 2017 in Neurogastroenterology and Motility compared these findings from antroduodenal manometry to full thickness biopsies of the small intestine. So that means they actually sampled all the muscle layers. And so these are layers, when I do routine endoscopy, I'm just sampling the very inside of that luminal tissue. I'm not sampling the muscles. So I'm not able to get this information with standard mucosal biopsies, which most of you have probably had and been told are normal anyway. So this is a full thickness biopsy. So it's actually really quite interesting. So they took individuals who had a classic neuropathic pattern on antroduodenal jejunal manometry. And the reason this is considered neuropathic is that the black spikes up give you an idea about what the intraluminal pressure is. That's considered within the normal range. The problem is that they're non-propagating, because what you can see is they're all happening simultaneously. So that means that your bowel is contracting, but nothing's going anywhere. So this can be painful, this can cause bloating, this can cause nausea. And then when we look at what a myopathic pattern looks like on antroduodenal jejunal manometry, it's basically just lower pressure measurements from the lumen. And then when we look at an occlusive pattern, so this is basically just simultaneous contractions, a lot of them, this person does not move food through their gastrointestinal tract. They usually have a diagnosis of chronic intestinal pseudoobstruction. So then, if we actually go and look at what the results of the full thickness biopsy are, so this is looking under a microscope with special stains to look at different components of the tissue. And I'm going to draw your attention to kind of the upper right box where you have that kind of dark brown blob. So those are the control samples. So that's what the tissue is supposed to look like. But if you look in the cases, what you can see is that cluster of neurons there is essentially absent. So this is what we would consider an actual neuropathy, because the nervous system that is innervating the gastrointestinal tract is injured. That's not what they saw on the manometry testing. And then just to look at what a myopathy looks like. So this is a special stain for muscle. And what you can see is the staining is very different in the controls versus the cases. And so this is a direct injury to the muscle. This one I thought was particularly interesting. So this is an inflammatory neuromyopathy. So you have an injury to both the nerves and the muscle. And what they found is that in this particular case, they actually stained for tryptase. So they were staining for mast cells. And what they could see, if you look at all the little brown dots that are present in the cases and not the controls, is there's a dense mast cell infiltration within the muscle and nerve layers. And so, but what they found in the population that they looked at, that this could be mast cell mediated, this could be eosinophils that are there, or it could be lymphocytes. So either way, this is an immune attack on the muscles and nerves that's occurring. And again, I just want to remind you that this is not a diagnosis you could get from routine endoscopy, okay? So the take-home point from that section really is that the pathology does not correlate with the manometry. So maybe all we need is to identify that there actually is an anomaly, and then actually consider pursuing a full thickness biopsy to actually get the true diagnosis, because that would really change the direction of our therapy. And this is why I think the smart pill could actually offer this at a number of centers rather than these specialized centers that can perform the intraduodenal jejunal manometry. So some of you may recognize this, but this is a tracing from the smart pill wireless motility capsule. So essentially you fast overnight, you present to the endoscopy suite, and you swallow a capsule, and it's pictured above. It's a little bit bigger than a video capsule, which some of you may have had. It's quite big, but people managed to get it down. And then what the capsule does, you wear a recorder for up to 5 days, is it measures temperature as represented by the blue line at the top of the screen. It measures pH as represented by the green line that changes pretty dramatically throughout the study. And then it measures pressure. And so the pressure is indicated by the red tick marks at the bottom. And so this person actually has normal transit times. So their stomach appears to empty normal, the transit time through their small intestine appears to be normal, the transit time through their colon is normal. But what's unusual about this person is that their intraluminal pressure measurements are actually much lower than one would expect. And so based on that prior paper, I can't say whether this is a neuropathy or a myopathy, but this individual has underlying dysautonomia with a neuropathic pattern. And so this may warrant further investigation because she has really significant enteral intolerance, which means that she doesn't tolerate eating by mouth. She doesn't tolerate tube feeds, and this may be the reason. This is just another example. So this is another individual with a hyperadrenergic form of POTS. And like I said, the sympathetic branch of the autonomic nervous system, it slows motility. This is your fight or flight. She is delayed in every single region. Delayed in her stomach, delayed in her small intestine, delayed in her colon. What I think is important is that many of you come to see me and you've had gastric emptying studies like the nuclear medicine gastric emptying study. But what I'm finding is that you're more likely to actually have small intestinal delays, and that changes the way we manage your symptoms, and it changes sort of what we'll do long term. So I think it's important to have a better assessment of what the motility of the entire gastrointestinal tract does, especially in patients as complex as yourselves. So what I find, again, is just high rates of regional and global delays. I see high rates of small intestinal delays, and this is much higher than they're seeing like at other centers, and I think it's because my patient population is unique. I think that potentially the smart pill could actually replace the need for intraduodenal jejunal manometry that's only available at specialized centers and provide us with an opportunity to investigate some of these diagnoses at more institutions. Now I'm going to switch gears. We're going to talk about breath testing. A lot of you are always sent for this, repeated courses of antibiotics. We're just going to come back to that slide from the beginning, and we're going to look at the numbers of microbes per region of the gastrointestinal tract. Breath testing is measuring the response of the microbes in the small intestine to a glucose challenge. I'm going to draw your attention to this paper. I'm not going to show you any data from it, but I'm going to just tell you what they did. So they looked at gastrointestinal motility in individuals with normal baseline who they exposed to elevated hydrogen or elevated methane. And what they found was that elevated methane levels slowed gastrointestinal motility significantly. And the reason that I think that this designation is actually important is that the organisms that produce methane are not bacteria. They're single-cell organisms. They look like bacteria to the layperson, but they are very different. They actually represent the third domain of life. So you have eukaryotes, bacteria, and archaea. And the reason that this distinction is important is their cell membrane is different than bacteria, which means that they do not respond to antibiotics that were designed to target bacteria. And so when you take an antibiotic to treat an elevated methane level, all you're doing is causing more microbial disturbance by going after the bacteria that are there, which then could potentially allow for an outgrowth of the archaea and cause more disturbances long term. So when I get a result of an elevated hydrogen level, I think about an anatomical defect. So many people can have outpocketings within the small intestine called diverticula that can contribute to this. You can also have a motility disorder, which is very common in many of you, and a dietary effect. Individuals who eat a lot of simple carbohydrates, processed foods, are much more likely to have elevated hydrogen levels. And so before I would prescribe antibiotics, I would look at these things and talk to patients about diet. The other important finding is that if there are elevated methane levels, I never treat with an antibiotic. I treat with a statin. It's usually a 30-day course. Some individuals require longer courses, but then repeat testing will demonstrate that the methane levels are no longer elevated and that motility actually improves. So SIBO measures, at most centers, both hydrogen and methane. So endoscopy, I don't have too much to say about this, except that when I do endoscopy, I like to do the procedures myself on my own patients because I take extensive biopsies. So I'll biopsy from everybody's esophagus. I will biopsy from the proximal, so the top of the esophagus, the middle of the esophagus, and the end of the esophagus, at least 4 samples, and I'll ask the pathologist to stain specifically for eosinophils and provide me with counts. Because many of you actually have underlying eosinophilic esophagitis that hasn't been diagnosed. And one of the reasons is that physicians oftentimes they rely on the endoscopic appearance of the esophagus in individuals who have eosinophilic esophagitis. However, what I've found is that many individuals actually meet criteria for it based on eosinophil counts, but their esophagus doesn't look classic. And the reason may be that this is actually different in dysautonomia or different in underlying connective tissue disease. And so it's something we have to be cognizant of and should be ruled out. I'll also biopsy extensively from the stomach in 2 different areas, multiple biopsies. I'll look for both eosinophils and mast cells. And again, from the small intestine, I'll biopsy extensively, and again, I'm looking for eosinophilic infiltration, mast cells, and then they'll always just tell us whether someone has suspicion for celiac disease. So now I'm going to talk a little bit about mast cell activation syndrome because I think it's super common in gastroenterology clinics and yet is missed frequently. So these are just some pictures of some mast cells. You can see all the granules on the right over there, and then when it degranulates, it releases a ton of mediators. Mast cells, if we look at sort of a cross-section of the gastrointestinal tract wall, they can be just about anywhere. We usually think about them sort of in that first layer, the mucosal layer. They're in close proximity to other immune cells. They're in close proximity to blood vessels and small nerve fibers. So when they release their mediators, they can have local effects and systemic effects. And then this was a great paper published in New England Journal in 2015, and this talks about all the mediators that these mast cells can release. The diagnosis, I think, is often overlooked because people are just looking for tryptase. I find that most of my patients actually don't have an elevated tryptase. And so what I've started doing is formalized mast cell counts. I understand this is not widely accepted, but I am seeing a correlation. When we have a little bit more data, we'll eventually publish the findings compared to true healthy controls. What's been published in the literature are called healthy controls, but many of them actually had irritable bowel syndrome, which actually could have mast cell activation syndrome, and they just weren't looking for it. Now I'm going to switch gears and talk about median arcuate ligament syndrome. So the median arcuate ligament is formed by 2 muscles, the left and right crura of the diaphragm, that cross around the abdominal aorta. It's supposed to sit approximately 2 centimeters above the origin of the celiac artery, which you can see in the top diagram. In some individuals, it sits a little bit lower. And so this is thought to cause compression of the celiac artery. And historically, that's been our diagnostic criteria. It's also called a couple of other things like celiac artery compression syndrome, celiac trunk compression syndrome, and Dunbar syndrome. Classically, when I came through training, I was told my patients would have postprandial, so that means after they eat, abdominal pain. This is because they thought the mechanism was actually compression of the celiac artery, and essentially you're cutting off blood flow after you eat. So it's essentially like a heart attack of the gastrointestinal tract where you cut off blood flow, which is the same thing that happens in a heart attack. And the diagnostic criteria required compression of the celiac artery. And so this is just sort of classic findings, classic CT diagnostic criteria. So on the right panel, you see the celiac artery coming off. I don't know if I can show you, right here, coming off the aorta. And what you can notice is this is the median arcuate ligament sitting right here. So it's actually abutting the celiac artery in this individual. And then during expiration, when you have the descent of the diaphragm, you actually see it compressing the origin of the celiac artery. And so this person meets the classic clinical criteria for median arcuate ligament syndrome, and they would be referred for surgery to release that ligament from compressing the artery. The diagnosis is debated, and the reason is that I think the mechanism that people have classically been thinking about is wrong. It's debated because the outcomes are terrible. So if the mechanism was so simplistic that this was compression of the celiac artery and we alleviate that compression, everybody should get better. They don't. The data ranges from anywhere from 30 to 70% of people improve with surgery, and it really depends on where you go, how the surgery is done, all sorts of things, delay in diagnosis. I argue, and I'm not alone in this, but this is not widely accepted, especially within the realms of gastroenterology. I think this actually represents a nerve entrapment injury. And so if you can look here, here is your celiac artery. You can see your celiac ganglia sitting right around it. So this is your major sympathetic input to the gastrointestinal tract. And I believe that this becomes compressed by that ligament that is in an anomalous position, and it's causing pressure on it. I think it's similar to complex regional pain syndrome, which is also associated with trauma, and I would argue that compression by this ligament is also a traumatic event for those celiac ganglia. It also explains why some of the patients, when I talked to them, their initial symptoms were actually abdominal pain, but now they have, and it was just after eating. And now they have abdominal pain all the time, and now they have dysautonomia. And so you could potentially see how activation within this component of the autonomic nervous system could actually spread, just like we see in complex regional pain syndrome, and cause a systemic dysautonomia. And so if you look, here is the celiac ganglion right here, and you can see it has postganglionic innervation to the liver, stomach, adrenals, and then you, through the superior mesenteric ganglion, which comes to the celiac ganglion, you have postganglionic innervation of the small intestine and colon. And so in these individuals, I see delays in gastric emptying, I see small bowel transit delays, I see significant abdominal pain, and many of these individuals have enteral intolerance, so they're usually on nutrition by IV or TPN. And so this is just sort of to drive home sort of the theory about what I think is occurring from this ligament compressing the celiac ganglion, is that you have an inflammatory response at that local site of injury, which initially causes pain, but then you actually have it spread. And then you actually see changes within the spinal cord and the central nervous system if that inflammatory cascade is not calmed down. So we've been working to actually improve diagnosis specifically in this population. And so what we've done is we've developed new CT angiographic protocols at our institution so we can specifically look at the position of the ligament in regards to the artery. And so what you can see in this individual is that his ligament is here, and here is your celiac artery. And then over here, this is expiration. So again, this is when we should have that classic compression of the celiac artery occur because it changes in the position of the diaphragm. What you see is that his celiac artery actually doesn't compress, but his ligament's still sitting there. It's in an anomalous position. So then we asked ourselves, well, where are the celiac ganglia in reference to this? Because maybe you don't have to compress the celiac artery. You can just be annoying the celiac ganglia. And what we find in these individuals, so I'm going to see you. This is the right celiac ganglia, and it's just adjacent to the origin of the celiac artery. And this is the left celiac ganglia. And so again, it's right in that proximity to the celiac artery, and very easily can be compressed by the ligament in this anomalous position. So again, I think this likely arises from compression of the celiac ganglion and is synonymous with a nerve entrapment injury, and much like complex regional pain syndrome, can cause an ascending process that results in a systemic process such as dysautonomia. It requires surgical decompression. There's a huge amount of debate as to how that should actually be done. We're working on changing the protocols at our university so that we're not focusing on just compression of the artery. If it's found early and decompressed early, it typically requires no further intervention. If there's a significant delay in diagnosis, which I think there is because the criteria has been so strict and I think missing the underlying pathophysiology, many individuals have suffered with this for many years. They have a systemic process now in the form of dysautonomia. They typically require immune modulation, and we're using IVIG therapy to reduce the inflammatory cascade that has resulted from the original injury. I'm just going to finish up with autoimmune disease. I actually think this is really important. I think it requires an extensive laboratory evaluation. I think it oftentimes requires repeating this, depending on the clinical scenario. And I think it requires treatment if detected. So just to summarize, this isn't in your head. Don't let anybody tell you it is. I think gastroenterologists are some of the worst culprits because they have failed to understand the complexity of the symptoms that can occur. Never be satisfied with a diagnosis of irritable bowel syndrome. It's not a diagnosis. It's a descriptor of symptoms, and that means that person is not willing to get to the bottom of what is actually causing your symptoms. Remember, this is complicated, and no one intervention will make you better, and not all tests are for everyone. And sometimes this is a process of trial and error with our treatment modalities. And so I always ask my patients to bear with me. I do think as the research progresses in this area, we'll have a better idea about which interventions are appropriate for which populations as we move forward, but we don't currently have that information right now. So I would just like to follow up with some acknowledgments. I work in a group called a neurogastroenterology working group. We share a number of patients with complex neurologic disorders, and it's actually been super helpful to have sort of the input from the neurologist. So Dr. Stacy Clardy is a neuroimmunologist, and she helps a lot with immune modulation and sort of identifying some of the underlying neuropathies that otherwise have been misdiagnosed. And then Dr. Melissa Cortez, she's an autonomic neurologist, and she helps with the diagnosis of dysautonomia. And then within genetics, Dr. Douglas Ball helps us elucidate whether individuals have an underlying connective tissue disorder and specifically what it is. And then within pathology, Dr. Maria Pletneva has been wonderful in performing the mast cell counts, as her department chair does not believe in mast cell activation syndrome and told all her other staff not to do these counts at my request, and Dr. Pletneva has taken it on herself to participate. And so I'm extremely grateful. And then within radiology, Dr. Mariam Rezvani has helped develop the new CT and MRI protocols. We're hoping as we move forward, we'll actually be able to go to just an MRI protocol because I don't like to expose people to radiation, excuse me, if I don't have to. Thank you. Do we have time for questions? Okay. Does anybody have any questions? Oh gosh, how am I going to pick? I'll start with you in the back. Yeah, I wish I had a better answer for that. So I've become the local person, and so my clinic is booked out nearly a year. I am hoping to get other people on board, but I'm always willing to help answer some questions by email or something like that to see if maybe we could facilitate some improvement at your facility. Mm-hmm.
That it was becoming more popular. Is it like you get it anywhere, or you're seeing more of it?
So it's actually more widely available because it actually doesn't require a significant amount of expertise for placement like the other manometry catheters do. And it's basically like a video capsule, which many gastroenterology practices actually have. And so it's not beyond what they know how to do. Some of the complexity with interpretation will have to be learned over time, but I'm hoping that it'll be more widely available.
It's not something you find like insurance squawk at or anything?
Oh, they do. I spend a ton of my time writing letters, but I think it's worth it, and I really do think that we are changing payers' minds, especially in complex patient populations, because they realize that if we can actually get an appropriate diagnosis, that's actually cost-saving in the long run. Yeah, so actually the treatment for the methane elevation with a statin, I have really good success with. It's the hydrogen that I have a little bit harder time with because until I can really improve a person's motility, it's hard to get that better. But we work on diet, we work on treating the dysautonomia, and people do get better.
I was curious, you were mentioning about mouth surgery that sometimes you can damage the nerve pathways there. I have a child who just got diagnosed with mouth 2 weeks ago, and they're telling me she should go to surgery. She's 10. It's something we should wait until there's further research to see if we can do more damage to her by doing targeting the nerves there?
That's actually hard to answer. What I would say is I would thoroughly investigate the surgeon that's doing it, ask them for their actual outcomes, talk to them about their approach and what they actually think, because I'm assuming that she has the classic compression of the celiac artery. Yeah, and so if you go to a surgeon that only buys into sort of the vascular etiology for malls, then they won't consider the ganglion and they won't do an extensive decompression that's necessary. And so I do see, unfortunately, a lot of people who don't get initially better after the surgery, even when the surgery's been done correctly, but they are getting better with IVIG. And so it depends on how long that injury has been present and sort of how effectively it is actually decompressed. I've seen a few of them. And one of the big keys is they don't respond to even the most aggressive therapies for inflammatory bowel disease. We also see it confused for eosinophilic disease as well. It's entirely possible. And so some of the slides that I showed you where they did the full thickness biopsies, it's not clear that those autoimmune mediated nerve injuries will actually improve. With that said, when you have a nerve injury and you actually do get improvement, those are sometimes really long time courses. And so you can't expect immediate nerve regeneration just because you've removed that sort of inflammatory attack.
Do you have recommendations for how to improve gastroparesis?
So I struggle with gastroparesis because I oftentimes feel as though that's not the only problem that actually exists. Because what's interesting is the degree of delay within the stomach does not actually correlate with symptoms. And I think the problem is because we're not actually looking at what's happening in the small intestine in most individuals. And so usually it's a more thorough evaluation to actually look at what the small intestine is doing. But I mean, there are basic dietary changes and things like that. I don't like a lot of the medications that are prescribed for gastroparesis because of the side effect profile, and I think that we're missing the underlying etiology. There is some interesting sort of work done looking at vagus stimulation with a gastric stimulator or other modality that if someone has really severe gastroparesis may be helpful, but there's not enough data, and I have not seen enough patients with dysautonomia have that put in place to see how they'll actually do, to really comment on it.